Welcome to our video on acute pancreatitis. Let's get started. Here is our overview slide, and you can see the order of topics that we'll be discussing with regards to acute pancreatitis. So let's begin with the definition. Acute pancreatitis is an acute inflammatory condition of the pancreas that leads to abdominal pain and elevated levels of pancreatic enzymes. It occurs when some triggers lead to inappropriate activation of pancreatic enzymes, which ultimately results in the premature release of active trypsin. Active trypsin and other enzymes in the pancreas lead to autodigestion of pancreatic tissue. As this tissue is destroyed, it releases even more active enzymes, creating a vicious cycle. Inflammation and vascular injury from the enzyme destruction then lead to shifting of fluid from the intravascular space to the interstitial space, which is sometimes referred to as third spacing. In addition, inflammatory cells migrate to the area and release cytokines, creating even more inflammation and destruction. Let's take a look at a mnemonic to help remember the etiologies of acute pancreatitis. The mnemonic we'll use is I get smashed. Now let's go through what each of these letters represent. I stands for idiopathic. Sometimes there is no clear etiology for acute pancreatitis. G is for gallstones, which is the most common cause of acute pancreatitis. E is for ethanol, which is the second most common cause. T is for trauma, which can lead to pancreatitis by damaging the pancreas and its ductal systems. S is for steroids. M is for mumps, which is a rare cause due to widespread vaccination against the virus. A is for autoimmune disease. S is for scorpion stings. H is for hypertriglyceridemia or hypercalcemia. E is for ERCP or endoscopic retrograde cholangiopancreatography, which can lead to pancreatitis after the procedure. And finally, D is for drugs. There are many drugs associated with acute pancreatitis, including, for example, valproic acid, nucleoside reverse transcriptase inhibitors, diuretics, metronidazole, and TMP-SMX. Of all of the etiologies within this mnemonic, the most common causes of pancreatitis will be gallstones and alcohol use. Let's take a closer look at the two most common causes. So again, gallstones and alcohol. While the exact etiology of how these triggers lead to acute pancreatitis is unclear, there are some hypotheses. It's thought that gallstones most likely lead to acute pancreatitis either by causing transient obstruction of the ampulla vator or creating edema as they pass through the ampulla, which also leads to obstruction. This obstruction, either from the stone itself or edema, can allow bile reflux back into the pancreatic duct and prematurely lead to the activation of enzymes. Alcohol is the second most common cause of acute pancreatitis, and this typically only occurs in the setting of years of alcohol abuse. The mechanism is unclear, but one hypothesis is that pancreatitis may be due to products of alcohol metabolism, which in turn leads to pancreatic damage. Acute pancreatitis will present with sudden and severe epigastric pain that radiates to the back. Many patients describe it as radiating straight through them. The pain also worsens with food intake. It's almost always associated with nausea and vomiting, and patients may completely lose their appetite. It can also be associated with fever and tachycardia. On physical exam, the patient will have epigastric tenderness and may guard the area. They may also have associated scleral icterus if the acute pancreatitis is leading to jaundice. Additionally, the patient may have hypoactive bowel sounds due to ileus from the inflammation associated with pancreatitis. Additionally, the patient may present with characteristic skin findings. However, these findings are rare. One of these signs is the Gray-Turner sign, which is blue or black discoloration of the flanks. This sign occurs due to retroperitoneal hemorrhage in pancreatitis. The second dermatologic finding is Cullen's sign, which is blue or red discoloration around the umbilicus. This finding also occurs secondary to hemorrhage in pancreatitis, but instead of the blood products accumulating in the flank, the digested blood products migrate from the retroperitoneum towards the anterior abdominal wall. Here's an image showing Gray-Turner's sign in pancreatitis. This patient has several areas of discoloration on the flank, which represent areas of hemorrhage collecting in the retroperitoneal space. And here's an image of Cullen's sign. Again, notice that this is on the anterior aspect of the abdominal wall. In severe pancreatitis, patients may also have signs or symptoms of multi-organ failure. This is because the inflammation and injury associated with pancreatitis increase the permeability of the vasculature, which leads to the leakage of fluid as well as hypotension. In severe cases, patients can develop acute respiratory distress syndrome. This occurs when a fistula is formed that allows the flow of activated pancreatic enzymes to the lungs. Active phospholipase A, which is one of the pancreatic enzymes, can digest lecithin, which is a component of surfactant. and this digestion of surfactant can then contribute to the development of acute respiratory distress syndrome. Patients may also experience the signs and symptoms of hypocalcemia. This may include muscle cramps, perioral numbness, and signs of tetany. The signs of tetany and hypocalcemia include trousseau sign and Schwastik sign. Trousseau sign is when the pressure of a blood pressure cuff inflating around the arm leads to spasm of the hand. Schwastik sign is when tapping on the facial nerve leads to ipsilateral facial spasms. In pancreatitis, hypocalcemia occurs as lipase breaks down peripancreatic fat and fat in the mesentery. This releases free fatty acids that bind to calcium, which then leads to saponification within the tissues. All right, let's try a question. A 56-year-old woman is evaluated in the hospital for severe shortness of breath for the last 6 hours. She was admitted 2 days ago with epigastric pain radiating to the back, which was later diagnosed as gallstone pancreatitis. She was treated with endoscopic retrograde cholangiopancreatography. The physical exam reveals perioral and peripheral cyanosis. SaO2 is 86% compared to 95% 1 day ago. Chest X-ray shows diffuse opacification of both lungs. What is the most likely pathophysiology of this patient's respiratory condition? All right, this patient was admitted with a diagnosis of gallstone pancreatitis. Now she's presenting with cyanosis, hypoxia, and diffuse opacification of both lungs. So this presentation is most consistent with ARDS, which is induced by acute pancreatitis. Again, acute pancreatitis causes a release of pancreatic enzymes into the bloodstream. And one of these pancreatic enzymes, which is phospholipase A, disrupts the pulmonary endothelium, degrades surfactant, and ultimately leads to ARDS. Okay, moving on to diagnosis. There are several labs and imaging studies that should be ordered. The most sensitive diagnostic labs for pancreatitis are serum lipase and amylase. A comprehensive metabolic panel should also be ordered to determine if there is any liver damage and also to look at electrolytes such as calcium. A CBC should also be obtained to evaluate for hemorrhage or investigate for potential signs of infection. A lipid panel should also be obtained because recall that hypertriglyceridemia can be a cause of pancreatitis. Imaging should start with an ultrasound to look for gallstones, since this is the #1 cause of acute pancreatitis. On ultrasound, you may also see peripancreatic fluid and a diffusely enlarged pancreas. If an abdominal X-ray is obtained, there may be signs of localized ileus of the small intestine, which is visualized as a sentinel loop on the film. A chest X-ray may reveal a pleural effusion, which is due to transdiaphragmatic lymphatic blockage or a fistula, allowing leakage of pancreatic fluid into the chest cavity. Pleural effusions associated with pancreatitis will typically be on the left side of the chest, which is directly above the pancreas. However, in severe pancreatitis, you may see signs of acute respiratory distress syndrome on X-ray, such as patchy ground glass opacities. Another imaging study that can be used is a contrast-enhanced abdominal CT scan, and some of the findings here include an enlarged pancreas and heterogeneous enhancement of the pancreas. Here is a CT scan of a patient with acute pancreatitis. And notice the pancreas right here. And around the pancreas, exudative fluid can be seen, which is indicative of the inflammation associated with acute pancreatitis. The diagnostic criteria require 2 out of 3 of the following findings. First is the clinical presentation of acute onset severe epigastric pain that often radiates to the back. Second is the laboratory findings of serum amylase or lipase elevated to 3 times the normal limit or higher. The third potential requirement is characteristic findings of acute pancreatitis on imaging. So notice that imaging is not necessarily required for a diagnosis if the patient has the typical clinical presentation as well as elevated pancreatic enzymes on labs. Okay, moving on to management. Management is mainly supportive care. One of the most important aspects of this is maintaining appropriate hydration with IV fluids. Analgesia is also important since many patients with acute pancreatitis experience severe pain. Patients should be made NPO when they're first admitted to the hospital and can transition to oral feeding as they tolerate it. If patients do not tolerate oral feeding and require a significant time NPO, then enteral feeding with an NJ tube should also be started for nutrition. After all of their supportive care is started, patients should be monitored closely for any signs or symptoms of systemic complications, such as hypotension or ARDS. In addition, if patients are found to have acute pancreatitis due to gallstones, they may require ERCP or cholecystectomy to remove the stones. One complication of acute pancreatitis is an abscess in the pancreas. This should be a suspected complication if the patient begins to develop fever and leukocytosis during their hospitalization. The abscess should be aspirated using CT or ultrasound. If the fluid shows that there is an infection present, the patient should receive antibiotics. And if the abscess persists, the patient may require surgery. Another complication to be aware of is a pancreatic pseudocyst. This complication typically presents with persistent abdominal pain with an epigastric mass. It's due to a collection of pancreatic fluid that becomes surrounded by a wall. While this can be a complication of acute pancreatitis, it's more commonly associated with chronic pancreatitis. These pancreatic pseudocysts are diagnosed with a CT scan showing the cyst within the pancreas, and typically these pseudocysts will spontaneously resolve. Here is a CT scan of the abdomen in a patient with a large pancreatic pseudocyst. The body has walled off this large collection of fluid in the pancreas, leading to the cyst. As you can see here, pancreatic pseudocysts can be quite large and may even be palpated in the abdomen. All right, now that we've covered the information, let's finish up with a final question. A 49-year-old man comes to the physician due to dull epigastric pain for the last week. 2 weeks ago, he was hospitalized due to alcohol-induced acute pancreatitis. His amylase levels were 3,000 at the initial presentation. Now his amylase levels are 1,000. He has also noticed early satiety, and he sometimes vomits what he has recently eaten. He has never had such symptoms before. What is the best next step in the management of this patient? All right, this patient had alcohol-induced acute pancreatitis with high amylase levels 2 weeks ago. He also has persistently high amylase levels. Additionally, he has early satiety, and sometimes he vomits what he has recently eaten. This latter finding is consistent with gastrointestinal obstruction or narrowing. Considering his previous history of pancreatitis, the patient most likely developed a pancreatic pseudocyst. So the best next step in the management of this patient is an abdominal CT scan to confirm the diagnosis. And that concludes our section on acute pancreatitis.